Well, I'll go ahead and get started. Thank you guys so much for sitting here today and listening to me talk a little bit about my experiences in Kenya. My name is Kristin Long, and I'm an endocrine surgeon at the University of Wisconsin. I'm a native Texan and just recently moved up there to get started with my practice. And since I've been there, I've had the opportunity to get involved with Kenya Relief, which is an organization you'll hear quite a bit about at the conference over the next couple of days. They're doing some phenomenal work building surgical capacity in Western Kenya. And so we're going to talk a little bit about what it's like to kind of go on a surgical safari and some of the struggles with trying to do something that's highly complex with essentially no resources. So we have a couple of goals for today's talk. The first is to talk a little bit about the disparities in surgical availability in Sub-Saharan Africa. We're going to talk a little bit about some of the unique models of trying to build surgical capacity that maybe think outside of the box a little bit, and talk a little bit about some of the challenges of providing surgical care in very resource-poor settings. So those are the take-home goals, but there's one fourth hidden goal that we want to talk about, and that's hopefully to inspire you guys to be involved in humanitarian, medical, or surgical work in some way, shape, or form. And I think part of what's so wonderful about the M3 conference is that you really can find a place for everyone. And even if you think there's no way you can be of help, you can find a way to take that first step and get your involvement. So for a little bit of background, I'll give you guys some of my story. I will say I'm older than I look, but for anybody that's about my undisclosed age, this is your image of Africa, right? This is what we grew up with, was the Lion King, and we all thought about the fabulous animals and what it would be like to go there. And for me, my story is a little bit different. I did grow up in the time of the Lion King, but I'm also a small town West Texas girl whose father is very Texan, and I grew up the daughter of a big game hunter. So this was my living room growing up. I grew up surrounded by lions and zebras and antelope, and always wanted to go to Africa in some way, shape, or form. But not being a hunter, not being a terribly good shot, that was not my calling. Instead, I chose medical school and went from Texas, where I finished my medical training, to Kentucky, where I did my general surgery residency, and then ultimately had an opportunity to go to Kenya, so far away across the ocean, on a medical surgical trip with Tenwick Hospital, which you guys also will hear about here at this conference. And then came back to the States and finished up my general surgery training, and hadn't had an opportunity to go back for a couple of years. When you're a chief surgical resident, your time is not really your own. And finding an opportunity to get overseas and do mission work is not really an option. So when I came back and finished my training, I finished my fellowship here in Houston, just down the road at MD Anderson, and then was offered a job in Wisconsin. So this is where I live now, in the snowy, snowy land of Wisconsin. It's an actual picture. It's not really. And shortly after starting my first faculty job, I was offered an opportunity to go with Kenya Relief on a short-term medical mission trip to Western Kenya. And the predominant type of surgery done in this setting is thyroid surgery, which just happens to be my specialty. So I went in January of 2017, had a fabulous opportunity. We did about 50 surgeries in 3 days, helped a ton of people, and was blown away by the concept of doing surgery in almost an ambulatory surgery model. Most of what we see when we're talking about global health is building a ER or a clinic, and then building a medical ward and a pediatrics ward, and slowly getting your way up to surgical capability. But here, we're able to do safely chosen large volumes of surgery in essentially an outpatient setting. And I think that really shifts the thinking on how can we get surgical availability to more people. One of the problems with global health is that surgery is very, very underrepresented. You don't think about surgery being in the realm of even public health. And so I was exposed to this and then decided the next best thing was to become educated. And that's when I learned the scope of the problem. These are figures that you may see from other speakers as well, because this is well known from the Lancet Commission on Global Surgery. There are 5 billion people in this world out of 7 billion that lack any access to surgical care. And that's something as simple as appendicitis, a cesarean section, open fracture reduction. People still die from that routinely. The estimate is that 143 million additional surgeries are needed every single year to treat that. And that means 2.2 million more of me, more surgeons, more anesthetists, more obstetricians to try to treat these surgical diseases. But there's a little bit of a problem with that problem. And I don't know if any of you know surgeons, but sometimes we come with baggage. We need a lot of stuff to be able to do what we do. I can't simply pack up my entire practice and put it in a suitcase and take it to Kenya. I need an anesthetist. I absolutely cannot do what I do without an anesthetist or anesthesiologists. I need pre-op and PACU nurses. I need OR nurses. I need equipment. And then I need hospital resources like social work to help my patients get home after I've put an incision on them and potentially removed an organ from their body. So I can't be a one-woman show as much as I'd like to be sometimes. And so building surgical capacity is a much bigger challenge than some of the medical outreach programs that initially started in the world of public health. And that's led a lot of people to question, can surgery even be a public health initiative? Is this worth our time, our energy, our investment? And the answer, as we've started to slowly build some data, is absolutely yes. Surgery can be a public health initiative. If you look at this figure here, the estimate is about 30% of all household deaths, and this was in a study done in Rwanda, were potentially surgically treatable and therefore avoidable deaths. That's a large number of people that could be saved by even the most basic surgical treatment. To put a more staggering number on that, let's look at this. The estimate is, per year, 1.8 million deaths per year could be averted by just essential surgery being available. And that's the most basic first level things. That comes down to 1 death every 18 seconds that we could be avoiding. Now, to decide what exactly is essential surgery, the Lancet has also developed what we call the bellwether procedures. And that defines the 3 basic things that should be surgically available. So a laparotomy for trauma, for emergency general surgery, open fracture reduction, and cesarean section. So if you could provide those 3 things, you can provide essential, basic, first-level surgical care. How much does that cost? Interestingly, when you actually look at disability-adjusted life years, basic surgical services come out to be more cost-effective than even antiretroviral therapy for HIV. So extraordinarily cost-effective and beneficial, and has the potential to save a massive amount of lives. So why do we struggle to build this? One of the interesting things to look at is there's major gaps in basic surgical needs. So we're going to talk about each of these in turn. The first being clinical supply. It's sort of like an island when you're operating out there in the middle of nowhere. If you don't bring it, you may not find it there. So this is our pharmacy in Migori. And you can see there's about 10 bottles of Tums right here in the front that I brought as a thyroid surgeon, thinking one of my most dreaded complications is patients having trouble with their calcium after surgery. Realizing that something as simple as antacids, which are essentially calcium, might not be available, I packed almost an entire suitcase full of things like that. So just getting those clinical supplies can be a struggle. All of our operating equipment has to come over. Very little of this is available locally. This is one of our ORs, and you'll notice there's 2 operating tables in each room. So we do back-to-back surgery, which is something that you would never think of seeing here. Although I have to tell you, it's often fun to be operating with your friend right behind you saying, hey, how's it going? Can you look at this? What do you think of that? It's a very collaborative effort, and we're able to move patients quickly and safely through this operating room. The second thing we have to look at is access to care, and this has several different components. Mostly for patients, we have to look at time to care. How far away are they? For our clinics in Migori, we have patients that will come a whole day across the country on the back of a motorbike and sleep on the front lawn for 2 or 3 days waiting to be seen. When we arrive, there are already tents of families set up waiting for somebody to see them and offer them even the most basic medical care. We have to make sure that this can be provided safely. A lot of patients will visit practitioners within their cities or counties of varying levels of medical background or no medical background. We still have patients who visit witch doctors trying to get local remedies. And we unfortunately have people who practice far outside of their scope of medicine, doing things that are not safe and actually harming some of these patients. So we have to make sure that what we offer is significantly higher quality and safer than anything else they can get anywhere in the country. We have to make this affordable. These statistics are a couple of years old, but the estimate was in 2013, the average Kenyan had a $2 to $3 daily income. That's less than what we pay for our Starbucks every day. And that's their entire day's wage to provide for themselves and their family. So we can't charge them hundreds of dollars for procedures. We also have to make sure that we mitigate some of these delays. Patients will often wait. They either don't have medical care available or they don't think they can afford it, and they will delay seeking treatment until the disease is at a far more severe state than anything that we would wait to go to the hospital for. They may not be able to find it. It may not be close to them, and they may not be able to receive care once they get there. We've often seen patients who went to one facility for blood work and then were told you need to go to this facility for imaging, and then you need to go to this facility for something else. And when somebody is living on $2 a day on a motorbike, that is prohibitive for them to actually get appropriate medical care. This is the level of disease that patients come to us with. You can see this gentleman here had a large mass on the side of his neck. This woman here, unfortunately, had a massive compressive thyroid goiter. And these are extremes of disease. So by the time these patients get to us, it's often challenging for us to even be able to say, yes, we can do this safely in this setting. We do have to charge something because we have to be able to keep the lights on. And so this is a list of our fees that we charge for surgery. Now, a thyroid surgery, which is one of the ones at the very top here, small to medium, is listed for about 7,000 shillings. That's about $70, start to finish, for the entire surgery. I don't know what actually comes back to my hospital, but I know that my bill, what goes out, not on my behalf, but on the hospital's behalf, for a thyroid surgery is about $10,000. So there's a pretty huge discrepancy there in what we get and what we can offer these patients for relatively low cost. And this is enough just to help us keep the doors open. I give you an example here of a gentleman that I saw this January during my last trip to Kenya. This is JT, who's a 28-year-old gentleman. And he came into the hospital for a broken femur. So one of the strongest bones in the body, broken in a fall from standing, which shouldn't happen to a healthy 28-year-old male, right? Pretty hard to break that bone. Coincidentally, he had also had a prior humerus fracture, another really strong bone. But of course, in that time and in that setting, he never sought treatment for it. So that's his healed humerus right there at a right angle. That's how he lives with that. But unfortunately, by breaking his femur, he couldn't just ignore that and present it to the hospital. As we were able to evaluate him further, we noticed that his CT scan demonstrated that he had kidney stones, and he also had a large neck mass here, which for anybody that has practiced endocrine surgery is bells and whistles for what we call primary hyperparathyroidism. Now, this is a disease that I treat every single day in my current practice, and it is almost never to that extent of disease. This is something that probably could have been identified years earlier and treated for this gentleman. So, as we do in all operating rooms, we put the images up while we operate. We were able to ultrasound this gentleman and see that mass right there. So we have some pretty good technology at our fingertips here. This was actually done at one of the nearby medical schools that I went to visit for a few days before my time in Migori, and we had no less than 17 medical students crowded into the OR wanting to see this operation. This is a disease that they had never seen diagnosed or treated surgically before. So the hunger for knowledge and the potential to train local providers is there, and that's what we're hoping to build on. And we were able to take out about a ping pong ball-sized tumor out of this gentleman's neck that hopefully will cure him of his disease. Now, a normal parathyroid gland is about the size of a grain of rice, and that's what we took out of him. So clearly that had been there for quite some time, and this has a tremendous potential to make him feel better. But that's just meant to show you the level of disease people will let things get to. And he had been seen by other providers, but certainly nobody that could recognize this was a problem or even an easily surgically treatable problem in the right hands. And that brings me to the third gap that we have, which is looking at outcomes and quality of care in this setting. We have to ensure that whatever care we're providing, our outcomes are good and our patients are safe. Most of our patients that we operate on in Migori go home the very next day after surgery. And home may be 5 hours on the back of a motorbike. So how can I, as a surgeon, say, you're good to go, no risk of complications, no risk of long-term complications? I can't say that. And so the next step for us is continuing to build our outcomes and our follow-up data, which is something that's severely lacking in many of these settings. Another example of the quality of care that's often provided outside of our hospital from other outlying facilities. This is a physical exam from one of the patients that we saw. And the sum total of her physical exam right here is sick looking. Now, anyone with a medical background knows that's not really going to cut it for a physical exam. You need a little more information than that. And they're not wrong. She was, in fact, very sick looking. In fact, she has a lethal disease. But medical providers should know a little bit more than that. And that's why we're hoping to continue to teach and build this capacity. So clearly we should do it. We should try to help and build and treat patients with surgical disease and avoid these avoidable deaths. But how do we do that? It's not an easy thing to build. And I have friends in public health programs who say, well, you need a fully formed healthcare system. And I say, you are 100% right. We do. And if you can drop one into Western Kenya, you let me know, because it is a struggle and it is literally building from the ground up. Some of the literature has examined short-term mission trips versus long-term, temporary versus permanent. What's the ideal way to provide care for these patients? The jury's pretty much consistent in saying that temporary short-term platforms are really not that desirable. Drop in, drop out is not great for patients. You can treat a lot of patients, you can provide them with some care, but then you're gone. And you might leave them in a worse situation than when you came. If they have a serious complication and nobody's there to deal with that, perhaps it was better if you were never there. Temporary, self-contained platforms is pretty much where Kenya Relief is right now, in that we're not fully present 100% of the time, but we have a self-sustaining hospital or clinic that has been built. There's a nurse practitioner who runs it 365. Surgical teams come in and out. Our first inpatient building is opening this summer, and we'll have the capability to have 23 inpatient beds full-time. So we're working our way towards our goal, which is here, to become a surgical specialty hospital. And the data shows that that is about as effective as the outcomes in developed countries. It's the most cost-effective of all of these competing choices for a mission platform. It definitely has the platform for sustainability, and there is a clear role for training low and middle income country surgeons in that setting. We'll talk a little bit in just a bit about how we're trying to do that as well. So everybody wants to know, well, what's it like over there? What do you do? So in an afternoon of clinic, we usually see about 300 patients in a span of 5 hours. These patients have mostly been pre-screened for us, so that we at least know that they have something resembling a thyroid problem, which usually means they have some sort of swelling in their neck. Whether that's actually thyroid, that's what we get to determine. So we have our big intake room here. We're able to bring in patients, line them up with their intake forms, and slowly move them down the hall, chair by chair, until they get to the actual clinic room, where there are usually 4 surgeons, each standing behind their own curtain, with their interpreter and their nurse and their scribe, trying to quickly assess the patient and determine, is this a problem that's surgical? Is it a problem that's safe to be treated in this setting? And is this patient safe to undergo surgery? So it gets quite warm in there. We have a lot of people crammed into a small space, but in a pretty rapid amount of time, we're able to fill our 3-day OR schedule. We have the ability to ultrasound our patients, which for any neck surgeon is absolutely imperative for us to do surgical planning appropriately. The equipment works better sometimes than others, the electricity, same, but we learn to work around that. This was our surgical fellow, Dr. McDowell, this year, ultrasounding a patient and teaching both our interpreter and our visiting nurse what we're looking for with thyroid ultrasound. So not only am I able to take our trainees, but our trainees are teaching others as well. And it's really a completely mutually beneficial educational exchange. These are the examples of what people tend to come in with. So a fairly large thyroid gland. But sometimes we have some surprises. So this is another patient who came in with a thyroid goiter right here. Didn't look all that significant. Walked in, was breathing room air, talking comfortably, said, yes, I have some neck swelling, but it doesn't really bother me. We were able to perform an ultrasound on her, and that's when we noticed that looking at her thyroid, it definitely looks enlarged, but what's more concerning is that little sliver of black right there, that's her trachea. And the trachea should be perfectly round, like this. So this is telling us that her airway is compressed to about that. And that's a potentially life-threatening problem, both as she's walking around on the street, but also for us when we go to put our breathing tube in. This patient may not survive intubation. So we have to know these things in order to provide safe surgery. And we actually weren't able to do her surgery in our setting. So part of the way you grow this surgical capacity is recognizing what your limits are and recognizing what is safe to do in this setting and what is not, and then knowing where can we refer that, how can we build our network so that the patients that come to see us, but we can't appropriately treat, have some place to go and we can reliably send them there. This is our pre-op area. So beds 1, 2, 3, and 4 coincide with OR tables 1, 2, 3, and 4. And then once the patients are done with surgery, they come out. There is our list. We call this the HIPAA board, because as anyone who works in a hospital knows, you're not really supposed to have names up here, but we have no other way to keep track of our patients. There's our OR once more. And this is our OR staff. We have a lot of local visitors that come and help us out. And you can see the OR table in the background there. Very minimal things opened up. We don't open near what we would use in a lot of other settings to perform the same amount of surgery. There's another example of a really enlarged thyroid gland. This one was able to be done safely in our setting because they did not have any airway compromise. Here's a couple of more operating room pictures just to show what we typically are dealing with. This was one of our surgeons this year teaching 2 of the Kenyan surgical residents. So for the first time, we were able to have actively training residents come down from one of the nearby hospitals and join us for 3 days of essentially thyroid surgery camp. Really high volume, doing the same surgery over and over and over with surgeons who do that every day. And I think both of those guys left feeling much more confident about performing that procedure in their own hospital. And that really is the key to building all of this, is we can build it and we can keep coming a couple of times a year, but if this can't sustain when we're not there, we're not making the difference that we need to be. Here's our recovery room. So again, patients line up, they roll out of surgery, monitors here to recover them, and there's little Post-it notes on each monitor. And I didn't really think much of it the first time I saw that, but then as I was bringing patients in, I started to look and see what those Post-it notes say. And they say, works, doesn't work at all. And you finally figured out we had patients where we were checking blood pressures on one monitor and oxygen saturations on the other one and just getting it done. Our PACU nurses who went with us originally were very nervous about trying to work in this setting and felt like they might be outside of their scope of practice. And you know what? You get into that setting and you figure out how to make it work. And you take turns and you say, well, I need a blood pressure. Okay, here's your monitor to check the blood pressure. And everybody works together, which is also something that, unfortunately, I think we're missing a lot over here, is the ability to work as a team and to simply focus on the task at hand and get the job done for the good of the patient. There's no, this isn't my job. This is everybody's job when we're there. Here's our equipment room. We have pretty good sterilization techniques. We do reuse a lot of things that normally wouldn't be reused in this setting. And what that teaches most of us is how much waste we have in our current healthcare system and what we can do with such limited resources. Laundry is done here in the corner of the bathroom and hung out on the trees to dry afterwards. Our patients move from the recovery room to what we call phase 2, which is a tent on the front lawn. And they hang out there, spend the night out there with their family, and then they're able to go home the next morning. So then when we're ready to let these patients go home, what do we do next? We have to think about discharging these patients. Many of these people, as I said, often travel more than 5 hours. They may be on the back of a motorbike with a friend and they've just had neck surgery. So we have to think about that. They may have no access to clean water. How are they going to shower? How are they going to keep their incision clean? They may not come back for follow-up. That's a big struggle for a lot of us because for thyroid surgery in particular, we study how much thyroid is enough to take out. If we take out too much, these patients may need medication for the rest of their life. How do we know that they are okay once they go home when there's a real likelihood we may never see them again? And finally, we have to think about modified discharge instructions. Everything's a little bit different over there, and I typically tell my patients, don't lift more than about 20 pounds when I let you go home. It never occurred to me that I would need to tell somebody, please don't carry anything on your head for a couple of weeks after surgery. A lot of this is fairly lightweight. That probably wouldn't cause too much of a problem. That might. So you have to think about the context in which your patients are going home. And it's very different from what you might see in your everyday practice. Never in a million years would one of my patients here carry that size rock on their head. I don't know how she does it. The women over there are unbelievable, and they do this without flinching, and they can do it without holding on. And I'm from the South, but I did not learn how to do that in etiquette school. I couldn't carry a book on my head, much less a rock. This is one of the family's homes. So again, mostly dirt, partly built out of manure, maybe, sticks, stones, no clean water, no hot water for sure, very questionable sanitary conditions. And so for a surgeon, that's extraordinarily important because it's not giving somebody a blood pressure medicine or giving them a vaccine where there's really no follow-up needed for that. My patients have wounds that need to be taken care of and need to be in a clean setting. So I have to think about how can I minimize the risk of an infection. So clearly there's a lot of challenges. Something that people often forget is thinking about Africa in perspective. I know there's a lot of focus on Africa, and I've also worked in the Middle East, and we'll allude to that a little bit later in the talk, but think about Africa in perspective. This is one of my favorite figures because I think it really shows you the size of that landmass. So this purple right here is the United States to scale with how big Africa as a landmass is. So you can imagine the number of people that are on the continent there needing help. This is another stark figure that shows the number of inhabitants per doctor, not per surgeon, but just per doctor. So the bigger numbers and the red numbers are the worst numbers. If you look at the United States, and I realize this is awfully small, that's about 390 to 1. So about 400 people for one doctor, primary care, any type of doctor. You get into parts of Sub-Saharan Africa, and it is 50,000 humans to one doctor. In parts of the country, it is 12 to 15 million people for one surgeon. And I love to operate, it's my favorite thing to do, but I cannot take care of 12 million people. No surgeon can. And so we simply have to get more people that can provide care into these settings. Everybody's terrified of going to Africa. Everybody says, am I going to get Ebola? So no, you will not get Ebola just by going to Africa. In fact, if you look at that same map of the continent of Africa, most places do not have any history of that, so it's a very safe place to go. You might have to deal with a power outage. I have operated in the dark with just my little battery-powered headlight. Fortunately, since this picture was taken, Kenya Relief has been able to develop much more sustainable power. We have generators that almost immediately kick on now. One of the struggles of building surgical care in this setting is the local power is not that reliable, particularly in Kenya. Mobile phone lines are fabulous. Everybody has a cell phone and Facebook, and that works great, but actual electricity to the buildings goes out a couple of times a day and may stay off for hours at a time. So now we at least have a generator that within a minute or two kicks back on and we're able to keep operating. But it's not fun for those of us who don't like surprises, surgeons, to lose all power in the middle of an operation. It makes you think really quickly on your feet about how to get through this quicker and get this patient out of the operating room. You may find yourself in a setting where you're the only female surgeon in a country, this was not in Kenya, this was in the Middle East, where they may not think women should be in charge. You have to learn how to think outside of the box there as well. So why do we struggle when we're trying to build surgical capacity in this setting? There are a lot more questions than there are answers. This year at the American College of Surgeons meeting, there was a phenomenal talk about some of the ethical considerations of global surgery as we try to build this. First of all being, what should the goals be? When we go over to another country as visiting surgeons, should our goal be to do cases that can't be done locally, that local providers may not be able to do? Or should our goal be to train those local providers to do that case themselves? I would argue that it's a little bit of both, because particularly the second option does not happen overnight, and we have to work on both sides. The second question is autonomy and scope of practice. If I take a resident, a surgical resident or trainee with me, should I allow them to operate a little more independently than they would be able to here in the United States because there's not as much regulation? How do we decide what's within their scope of practice? Should I, as somebody who does general and endocrine surgery, be doing something like a cesarean section? I don't do that every day. Haven't done that since medical school. What if somebody comes in extreme conditions and I am the only person to do it? I know how to do it. I remember reading the book. Should I be allowed to do that if that patient's choice is die or let me do a procedure that I haven't done in 5 years? What about standards of care and informed consent? Anyone who's ever been to the hospital or even the emergency room knows that you have to sign a consent form for any procedure that somebody does to you. What if you didn't speak the language? What if you couldn't read or write? How do I, as a physician, explain to you in a language that's not my own what type of procedure you're going to have and talk to you informatively about the risks of that surgery? How do we do that through a translator who's not a certified medical translator, who doesn't understand that you're literally supposed to translate word for word what I say? And I'm not sure there is a Swahili word for thyroid. I don't know what it is. And so I'm very beholden to those who help us talk to our patients about what we're going to be doing and what the real risks are. How do you deal with informed consent when your patient is coming to you having seen provider after provider after provider, hoping that someone will treat them, and all they want to do is say what you want to hear so that you will offer them the care they have so desperately tried to get? And you know sometimes they say things that may not be true because they want the treatment. And finally, how do we adapt all of our situations for global surgery in the setting of a natural or even a man-made disaster? What if I go, and again, it's been a couple of years since I was a practicing trauma surgeon. What if I go and operate in an active conflict zone? Should I be able to do things that I don't routinely do? Should we allow providers who don't normally do high-volume surgery to do surgery? There's a lot of talk about letting advanced practitioners, nurse practitioners, PAs, do some surgical procedures on their own, particularly cesarean sections. At what point do we allow people to practice in that setting, if it's to build more care? So I titled this talk Surgical Safari because I really got to thinking the last time we were in Africa that a safari literally is the Swahili word for tracking and observing the local population. In this meaning, it's usually the wildlife. But what if it were the patients? What if it were the people of Kenya and we're trying to figure out what's the best way to help them? The problem is that protocols aren't universal, and the standard of care for treating a disease here in the United States may not work at all over in Kenya. For example, not uncommon for me to take out an entire thyroid gland because thyroid hormone here is available at Walmart for $3, and anyone and everyone can go get it. It's not even available in parts of Kenya. So I have to completely change my operative treatment, what I would do for this patient, knowing what they may or may not be able to get or what they will or won't actually go and get. If it comes down to school uniforms for the kids versus the thyroid medicine, what's somebody going to do? I think a hard struggle for getting patients and even people to understand the challenges of global surgery is kind of summed up nicely in this slide. And I think if you don't take anything else away from today's talk, this is what I'd like you to remember. We talk a lot about equality, and we want to get everybody on the same level playing field, but that's not really what we're talking about in the world of global health. We're talking about equity. And what we really want is equity of care for people. We want everybody to be able to see the field, and that may require some people getting a little bit more of a leg up than others. So how do we teach? How do we work on this process of becoming independent practitioners in Kenya where we're not needed? I would love nothing more than to be out of a job. But how do adults best learn? I can't go over there and give lectures to Kenyan surgeons and then say, all right, guys, you're on your own, go operate. That's not the way adults learn a new skill. We have to teach for retention. We have to teach surgeons how to do a procedure and then leave them so that they feel comfortable doing that. And a lecture is not going to do that. We have to ask the local providers, what do they see as most effective? We love to come over there with our idea of this is what you need and we're going to solve the problem. I've tried to recruit surgeons to join me on these trips to Kenya before, and they've said, oh, well, I'm happy to come, but I'll need this, 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 and this, and I'm going to fix this problem. And I say, I don't really think that's how that's going to work. Why don't you talk to some of the local surgeons and see what they want, or if they even want you to come and help them? And what expectations do they have? Are they expecting us to come and do all of the cases, or do they want us to watch them and try to give them feedback, coach them through some of the surgeries and make them better providers? So we have a lot of ways to mess up as humanitarian surgeons. And there's a phenomenal article in the World Journal of Surgery called The 7 Sins of Humanitarian Medicine. And I'm going to talk briefly about what they are. The first is leaving a mess behind. And we've alluded to that already. You can't leave postoperative complications behind with nobody to help. You have to be able to choose your cases appropriately. You have to know what patients can I safely operate on and who needs to go to another bigger facility. Simpler is better when you're in a low resource setting. It's not the time to get fancy. It's not the time to create a new operation. It's the time to treat what you can do safely in that setting and recognize when to send the rest on. You have to match your technology to the local needs and abilities. It doesn't matter if you're able to say that you did the first laparoscopic adrenalectomy in the Amazon basin, if nobody will ever do that surgery ever again. If you're teaching the local residents things that are applicable to them, then you're doing your job. This was my first ever educational endeavor at Tenwick, trying to teach the local Tenwick residents some of our laparoscopic skills curriculum. And it actually worked fairly well. The problem is making it sustainable. After I was gone, not so much happening with that. So you have to make sure you're doing something that will stay even after you leave. A lot of NGOs, non-government organizations, philanthropic groups fail to cooperate or coordinate. There may be competition from one group to the other, and you may end up doubling your work. So one of the things that conferences such as this do is they bring everybody together, and we meet people that are doing the same thing. How can we work together to make this better? You gotta have a follow-up plan. One of my favorite sayings ever since I was a child is failing to plan is planning to fail. If you don't have a way to track your patients, you don't know what your outcomes are. You may think you're the best surgeon in the world, but you have no idea and no proof. If you can build a registry, you can follow up your patients, you can prove it. If you do return trips to the same location, you can go and see those patients next year and make sure they're doing okay, and then you know what you're doing is working. You can't allow politics, training, or other goals to disrupt your service. This is not vacation. This is not about getting your case numbers. I did block out training on this slide because I do think that it is educationally beneficial for our surgical trainees, medical students, nursing students to go and learn how to work in this setting for 2 reasons. One, they're gonna see things they've never seen before, and it's gonna change how they approach their practice when they come back. But 2, it's going to show them the magnitude of care that is needed in that setting. And once you've been, you can't really ignore this anymore. For somebody who's never been on a mission trip or never been to Africa, it's very easy to say, oh yeah, I see the commercials on TV or I see these pictures. But when you have gone there and you have held these patients' hands and you have seen people bring you a bag of peanuts as a thank you when they don't have a dime to their name and you've told them that their daughter is going to die, then you can't ignore that anymore. And you have to keep going back. It goes far beyond an idea or something fun. It becomes a calling for you. You can't go where you're not wanted. If the local authorities do not want you in that setting, if the local government does not want you there, you will never be able to successfully build a program. And you have to do all of this while respecting the local traditions and the rules. And finally, doing the right thing, but doing it for the wrong reason. A lot of people have very good intentions when they go on short-term medical trips. But what this is not is voluntourism. This is not about you. This is about the patients you're taking care of. And you're going there to give something of yourself. So why do we succeed? That's a lot of negative. Why are we able to even do this to the extent that we are? Kenya Relief has treated more than 125,000 Kenyan patients to date in the last 15 years. We're able to safely perform large volume outpatient surgeries with appropriate patient selection. And we're building community and regional relationships. This is the concept of ambulatory care, which, as we've shown in the United States, improves access, lowers cost, and may even lead to better outcomes. And if you build it, you guys all know what comes after that, right? So this is the cafeteria in January of 2017. It's literally sticks for scaffolding, and we walked through this. 1 year later, that's that building. And that's the cafeteria that's going to feed 500 plus students at the Kenya Relief Academy. It's pretty impressive what can happen. Unfortunately, it's not always a straight line. Everybody thinks success is just a straight path. That's more what it looks like. And anything in global surgery is up and down and backwards, and you have an idea and it doesn't work, and you do something different and you change your plan. But you can only change your plan if you have one. So I'm going to end with a couple of lessons learned from my trips to Kenya, and hopefully some inspiring words for you guys to take forward from this. The first is that we are the most fortunate people on this planet. To whom much is given, much is expected. There are 3 institutions that I've had the privilege of training and working at. I did my general surgery training at the University of Kentucky. I did my endocrine surgery fellowship at MD Anderson Cancer Center right down the road. And I now work at the University of Wisconsin School of Medicine and Public Health. Just look at the size of those buildings and the resources within. It's my privilege to work there every day, and it is my responsibility to take that to the world beyond those facilities. It's not really that scary, okay? Anybody who's seen little baby warthogs know that when they get scared, they take off running with their tail straight up in the air. They actually do that. But don't be scared. You don't have to run away from this idea. There's a way to go and do it safely and be very successful. To make the biggest difference, you got to find the greatest need. Go where the red numbers are. Go where there are literally no other physicians. This is probably, I think, the keystone quote in all of public health, and I think this rings incredibly true in our current world. The idea that some lives matter less is the root of all that's wrong with the world. And I think we've shown that we can change that, and that every life matters, and we have the opportunity to help. So before we finish up here, the last thing I want to do is show you guys a little short video that was filmed during our January 17 trip to Migori, Kenya. And then hopefully we'll have a few moments for questions. So. In the end of it, you get 100 times more than you give.
I would say that it'll probably change your entire outlook on life. Can you hear this okay?
We can do this.
We just finished 3 days of surgery here in Migori, Kenya with Kenya Relief.
One of the main things that I believe and that I want to live on beyond me, and that's that anybody who comes, anyone of goodwill who comes and wants to partner with us, we stand side by side. People from all backgrounds come together and you see the best in humanity come out.
Medical background, not medical background, are you religious, are you not religious? It really doesn't matter, it's the mindset that you come here in. You're coming to give something of yourself and leave it here.
That's what Kenya Relief has done better than any place I've ever seen, is he puts 20 random strangers together and says, you're going to work in the highest stress of situations and you're going to help people.
If you're thinking about coming and you're worried that you may not be able to participate or fit in, or that your skill set's a little bit different, just come. There is a need for everybody here.
You don't have to be a doctor, you just have to be a human willing to work hard.
We really have the opportunity to change lives together.
No one can do everything, but everyone can do something. When you really do put that ego aside and you're here for the greater good, it's not about you, it's about the patient who's on the table who needs your help. And that's all that matters at the end of the day.
It's not defensive medicine. You just come here and you just do what you know how to do best.
It's a really great thing to be able to take something that you do every day and make it into a very special, life-changing thing for somebody.
There's no sense of entitlement here.
There's no expectation, there's only gratitude. People just want to be helped.
Oftentimes we go day in and day out and don't get a lot of appreciation for what we do. The smiles of the people here are infectious. Coming here, you meet some of the most wonderful people in the world.
It just helps you remember the purpose of you being on this earth. You can come up with a million reasons to why not to come, but there's only one reason to come, is because you just kind of have to.
My friends and family tell me, well, I don't know how you do it, and having been here now twice, I think, I don't know how you don't. This is our responsibility to the world.
Just try it. Just step out of your comfort zone. What if you did? Just what if you did?
Okay, so with that, I will wrap up, and I'm happy to take any questions that any of you guys might have. Any questions at all? Crickets? Yeah. So I have actually only been working with Kenya Relief for a little about a year, almost a year and a half now. So, and it's, you know, when you're in an academic medical job or surgical job, it's not easy to get time off for this. So something that I went into my career negotiations with was the idea that I intended for global health and global surgery to be a part of my practice. So that's something I negotiated into my contract, is that they know I'm going several times a year, and it's not, I said, it's not going to count as vacation time. Because if you want me to build a program, which we are working with through the University of Wisconsin as well, you have to give me the time to do that. So it's progressive. I'll be going 2 more. I've been once in 2018 already. I'm going back in July and November as well. But Kenya Relief takes about 21 teams a year. So there's almost always somebody there. It's not all thyroid surgery. There are eye teams, dental teams, GYN, general surgery. There are some disability-focused teams that hand out mobility carts for people that are disabled. This has really turned into, rather organically, turned into a full community of service. And it's not just any one particular problem. There's the school, there's an orphanage, there is a prison ministry, there is anything you can think of. And we're continuing to grow and come up with even more ways to help the people in Kenya and really try to work and help to bring together a divided country. You know, the United States isn't the only place that's full of sharp divisions, and particularly in parts of Kenya, some of the tribal divisions can be pretty severe. And part of the goal of Kenya Relief, and this is the background of our shirts this year, is that we want everybody to come together as one, and that's all of us, but that's also all of the people of Kenya as well. Anything else? Okay, well, thank you guys so much for your attention.